Welcome to EasyMed. So today we will be discussing about depressive disorders. Now to start a discussion about depressive disorders, we must first understand what are the mood disorders. So mood disorders, primarily we have 5 mood disorders. So the 5 mood disorders are: firstly, major depressive disorder; so here the patient gets only depressive episodes. Then we have bipolar disorder, which is basically mania complemented with depression. Then we have hypomania, which is similar to mania, but the intensity is less severe. Less severe to this. We have cyclothymia, which is again bipolar disorder of lesser severity. This one is this, and this is bipolar disorder, again type of bipolar disorder of less severity. And the last one is dysthymia, which is again less severe and chronic form of major depressive disorder. Less severe form of this one. So basically, primarily if we see the main disease, we have these two: the major depressive disorder and bipolar disorder. Others, classification has been made due to variability in the intensity, in the severity. So now we come to depression. Now what is depression? You see, we have a tendency to say that I am depressed. You are not basically depressed, you are sad. So there is a difference between sadness and depression. Depression is a chronic or acute psychiatric conditions which are manifested with lot of symptoms. So let us check out on the symptoms. So first point to remember is this is the most common psychiatric disorder. This is more common in females, much more common in females than in males. The age of onset is around 40 years in most of the cases, and this is more prevalent in divorced and separated individuals, because melancholy and loneliness is a major etiological factor, and it can be found in medical conditions as well. For example, hypothyroidism and hyperthyroidism, and in adrenal disorders like the Cushing's syndrome and the Addison's disease. Now let's get on to the symptoms of this depression. So symptoms. So what symptoms we do have in depression? We can remember all the symptoms by a simple mnemonic called SIGE caps. So side caps S. Sleep disturbances. There are sleep disturbances like there is insomnia, or there can be hypersomnia. Now, in case of depression, where we have insomnia, there is a typical type of insomnia in some patients, which is called terminal insomnia. Terminal insomnia, or early morning awakening. Early morning awakening. Now, do all the people who get up early in the morning are they suffering from depression? Obviously not. The thing is, the sleep time is less. So what we know that the sleep time should be approximately 8 hours in every individual. So the sleep time is less, but still the person is waking up early in the morning. This is terminal insomnia. Then we have interest loss. Side caps. Interest loss. So the patient loses interest in things which were earlier interesting to him. This is also called anhedonia. And then there is guilt. There is feeling of excessive guilt. He feels that he is the only person responsible for everything. Every negative things which are going around, he is the one responsible. Guilt. Then energy. So there is lack of energy. There is lack of energy in the individual. Then there is next symptom is cognition. C. Side caps C. Cognition, or concentration. The patient can't concentrate on anything particular. There are negative thoughts and poor concentration. Then there is loss of appetite. And in case of loss of appetite, here in depression, two things are seen. Two opposite things, but both are seen in different patients. So there can be weight gain and there can be weight loss. Both can be seen. Then psychomotor agitation. Or retardation. So motor activity is changed. And this can increase or this can decrease. And suicidal thoughts can come to the patient, complemented with sadness. So these are the symptoms, the primary symptoms of depression. And how we shall remember it? We can remember it with the mnemonic side caps. S. Sleep disturbance. I. Interest loss. G. Guilt. E. Energy. C. For concentration. C for cognition. A for appetite. P for psychomotor agitation, and S for suicidal thoughts. Now we come to physical signs. In physical signs, two things are seen. One is Veragouth fold and another is omega sign. So this is basically Veragouth fold, this thing. This is Veragouth fold. And just for common knowledge or like general knowledge, this was actually first described by Charles Darwin. Then omega sign. Omega sign, this is like visible physical sign, like looking at the patient you can see that yes, this is the patient of chronic depression or acute depressive episodes. This is omega sign. So you can see, appreciate the difference. You can appreciate the difference here. See, please appreciate the difference. So you can see this shape, it takes the shape of omega. So you can appreciate the difference between omega sign and Viragoth fold on the forehead. Now let's come to severe symptoms. These things are mostly found in cases of severe depression, not in acute episodes or small episodes. In severe symptoms, we have delusion or hallucinations, then atypical features, like hyperosmia plus minus weight gain, melancholy, that is severe anhedonia, and we have catatonic features, which is stupor and negativism. Now let us talk about the etiological factors of depression. Now, before starting the etiological factor of depression, I would like to say that there are individuals who are more predisposed to depression, and there are individuals who can easily fight off with situations in life, and such individuals may get a small episode of depression like in few days or something, 2 days or 3 days, and they will recover, they can fight off. But there are individuals who are predisposed to depression, they need psychiatric and medical help. So let us describe the etiological factors. So firstly, there are biological factors. The biological factors, main thing is serotonin and norepinephrine. Serotonin and norepinephrine reduces drastically, and in some cases dopamine also reduces. Then there are genetic factors. No, apart from please do apologize me. These are now in biological factors. These are the neurotransmitter factors related to neurotransmitters. Apart from that, there are hormonal factors. Like there will be overactivity or hyperactivity of hypothalamic pituitary axis, overactivity, and there are neuroanatomical factors inside the biological factors, which is dorsolateral or prefrontal cortex activity goes down. So dorsolateral prefrontal cortex hypoactivity. Then there are genetic factors, and in genetic factors, primary factor is locus for CAMP, response element binding protein. This is CREB1 protein on chromosome number 2. So there is specific locus for CAMP, response element binding protein, on chromosome number 2. So this is a primary genetic factor. And there is another genetic factor which is responsible for this is serotonin transporter gene. Now there is a psychological theory apart from this. So this thing is seen in patients with chronic depression, and is also a cause of depression. What is this? This is Aaron-Beck triad. In Aaron-Beck triad, there will be 3 symptoms. The person will be negative about self, negative about future, and negative about environment. This is Aaron-Beck triad. And another etiology is learned helplessness. The patient thinks he has no control on events which are happening around him, and there is loss of motivation to act. So he is helpless, he feels helpless. No control on events happening. Now let us describe few more additional etiological factors. In additional etiological factors, conflicts. Now conflicts can lead to depression. So what do I mean by conflicts? By conflict I mean loss of loved ones. This can be an issue of losing, this can be a breakup issue in relationship, it can be a divorce, it can be death of some close relative or parents, and it can be death of wife or husband. So that is loss of loved ones. Anger turned inwards. In situations when the person is angry but he cannot express, due to surroundings he cannot express his anger, that is a very dangerous situation. This kind of conflicts often lead to chronic depression. Then ambivalence, that is inability to decide, inability to decide. And introjection, this is blaming himself for everything happening. Suppose a person goes with his friend's car, and in the road he meets with an accident. Maybe he is not responsible for the accident and everything, but he will be blaming himself and himself only. Or maybe the person had some quarrel with his friend, and the next day his friend, due to some accident, got admitted to hospital, and he will be blaming himself for this thing. So this is introjection. blaming himself. Then there are social factors which contribute to depression, like relationship issues, not loss but issues, husband wife quarrel, or quarrel in a uh, relationship, or quarrel with or problems with the parents, like this relationship issues, financial issues, unemployment, which is complementary to financial issues, and loneliness. Now, speaking about loss of loved ones, this basically comes under ENT, but I would like to describe here. There is a typical psychiatric condition which happens, not depression actually, but a typical psychiatric condition which happens due to sudden death or sudden loss of some loved individual in the life, which is called psychogenic dysphonia. Psychogenic dysphonia, or hysterical, or functional dysphonia. Now, this condition is seen in primarily in emotionally labile females. In emotionally labile females, the presentation will be loss of voice, and adduction of vocal cords on cuffing, and there will be history of stressful events, and primarily on ENT examination by laryngoscopy or by primary laryngoscopy or endoscopy, there will be no change in larynx. And the management is primarily psychotherapy. Management is just psychotherapy. Now let's discuss about the drugs which cause such conditions. Now, drugs causing depression: beta blockers, oral contraceptive pills, interferons, barbiturates, and steroids. Interferons can cause acute suicidal ideas too, and steroids, apart from depression, can cause mania. Now, history of chronic medical conditions can also cause depression. Main chronic medical conditions which cause depression are hypo or hyperthyroidism, vitamin B12 deficit or vitamin D deficit, and folic acid deficit, or some other chronic medical illness can also cause depressions. And another primary medical condition which causes depression is chronic pain syndrome. Now let us discuss the types of depression. So in types of depression, there can be single episode depression, there can be recurrent depression. Recurrent depression is when depression is more than or equals to two episodes. And there can be persistent depression, that is greater than or equals to 2 years. Depression is persistent for 2 years. Now these first three are complementary, like it's in a process. Then there can be premenstrual depression in women. There can be seasonal affective depression, that is the person can feel depressed in some seasonal in some season. Specifically, it can be winter, the person can feel depressed in winter, or he feels depressed in summer or autumn, like that. This is seasonal dependent depression. And there is atypical depression. Atypical depression is a huge topic. Now, let's describe it. In atypical depression, the symptoms which we find are, we find hyperphagia, we find hypersomnia, interpersonal sensitivity, by interpersonal sensitivity, what is meant is that the person feels angry and gets depressed when some specific things are said to him. Maybe someone speaks about he does not play football well and he goes into depression. Someone speaks that he is not good in his academics and he goes into depression, like this. This is interpersonal sensitivity. Then there is very typical condition, that is called Leiden paralysis. There is no neural or nerve disorder, but the person always stays in bed. But there is no neurological complications in the person. There can be obesity and craving for carbohydrates. And in the management of these cases, management is done by combination or single use of two types of medications. One is MAO inhibitor or monoamine oxidase inhibitor, and SSRIs, that is selective serotonin reuptake inhibitors. We will describe and talk about it just later on, or right now in the treatment section. Now in the treatment we basically use three modalities: psychotherapy, pharmacotherapy, and there are some other somatic managements. So in pharmacotherapy, a very important point to note is pharmacotherapy. Any antidepressant therapy takes 3 to 4 weeks to work. So you give patient a prescription and after 2-3 days he comes to you and says, doctor, it's not working, please change the prescription. That's not how it works. It takes at least 3 to 4 weeks to work. So now let us first talk about pharmacotherapy. So what drug choices do we have in pharmacotherapy? We have tri or tetracyclic antidepressants, now this tri and tetracyclic antidepressant, how it works is, the basic mechanism is blocking of serotonin and norepinephrine transporters, and then due to blocking of these, there is increase in their level in the synapses. So serotonin and norepinephrine increase in synapses. But there are varied side effects of these drugs as well. Apart from blocking these drugs also acts in antagonism to H1 receptor, histamine 1, alpha 1 receptor, alpha 2 receptor, and cardiac sodium channels. Now, so what are the side effects? Side effects: constipation, urinary retention, blurred vision. These are due to the anticholinergic effects. What else? There can be postural hypotension due to alpha block. Arrhythmia and hypotension as well due to block of the cardiac sodium channels. Due to block of the cardiac sodium channels. And another side effect is sedation. The sedation is primarily due to the effect of H1 block. Particularly a drug called amoxapine. Now, amoxapine causes D2 block, dopamine 2 receptor block, and there are extrapyramidal side effects or extrapyramidal symptoms. Now, few example of this tri and tetracyclic antidepressants are imipramine, amoxapine, protriptyline, clomipramine. Now, in the next group of drugs, let us discuss a very important group, which is SSRIs. SSRI. Now, what I mean by SSRI is selective serotonin reuptake inhibitors. Now, these primarily has an effect of serotonin reuptake block. Now, example of these drugs include fluoxetine, fluvoxamine, citalopram, sertraline, and vilazodone. Actually, not and vilazodone. There are a lot of many more drugs, but yes, these are very frequently used drugs. Now, a point to note here is that these SSRIs in combination, when combined with MAO inhibitor or L-tryptophan or low dose lithium raises plasma serotonin concentration. Plasma serotonin concentration is raised, and this is called serotonin syndrome. Serotonin syndrome. This is very frequently talked about, serotonin syndrome. Now, how will you manage if you have a patient of serotonin syndrome? The basic management for serotonin syndrome is cyproheptadine support. Cyproheptadine support. And what are the manifestations? The manifestations of serotonin syndrome. These are diarrhea. There will be restlessness, hyperreflexia, hyperreflexia, and myoclonic seizures. The next group of drug which we should discuss is SNRIs. SNRI. What is SNRI? SNRI is selective norepinephrine reuptake inhibitor. This causes blockade of neuronal serotonin. A few mention-worthy drugs from this classification are venlafaxine, desvenlafaxine. See, very easy to remember. Venlafaxine and desvenlafaxine. And duloxetine. Next are the MAO inhibitors or monoamine oxidase inhibitors. What it does is it inhibits MAO or monoamine oxidase metabolism. Now in the MAO there are two types. There is MAO A and MAO B. Now MAO A principally acts on serotonin, norepinephrine and dopamine, and MAO B acts on only dopamine. Very important thing which I would like to mention here is the cheese reaction. So when a patient is on drugs like the MAO inhibitor, when the patient is on MAO inhibitor, there should be categorically prohibition of cheese, red wine, beer. A big no to these products. If not, there will be increment of levels of like there will be hypertension. So basically these things causes hypertension. Now there will be hypertension, and not only hypertension, but there will be hypertensive crisis when when a person would use MAO inhibitor and would consume these substances. So, and this is called the cheese reaction. Now let us name few drugs which are famous among the MAO inhibitors. So famously used drugs are carboxazide, phenelazine, phenelzine, and selegiline. Now the last group of drugs, very important group, these are the atypical antidepressants. Atypical antidepressants. Now, among the atypical antidepressants, I won't be going into details in this video. The main drugs you should remember are bupropion, and point to be noted, this is also used for rehabilitation therapy to get rid of the habit of smoking. This is also used to get rid of smoking. Okay, bupropion, then mirazapine, mirlazapine, nefazodone, and vilazodone. Now this bupropion, an important point to mention about bupropion is that they increase norepinephrine and dopamine. And hence there is insomnia. And this drug is never given in patients with epilepsy, never given in epileptics and anxiety as well. Now we would describe the next modality, which is psychotherapy. So in psychotherapy, there are a lot of modalities which are used by clinical and non-clinical psychiatrists, like psychiatrists and psychologists. So main mention-worthy types of psychotherapy are behavioral psychotherapy, they correct the cognition and faulty behavior. Interpersonal therapy, they are used for managing current interpersonal problems, that is relationships. Basically this is relationship management. And there are other types of psychotherapies. These are the two main types of psychotherapies which are widely used. Others can be family therapy, there can be goal-based psychotherapy. In goal-based psychotherapy, basically you give the patient a goal that you will achieve this when you do this. So that's the kind of correction which are made. And last but not the least, we would like to discuss about the last modality, which is the other somatic therapies. Other somatic therapies. So in other somatic therapies, there is electroconvulsive therapy or ECT, which is basically we have seen in movies and heard of a lot of times by the name of shock therapy. That is the electroconvulsive therapy. So electroconvulsive therapy is given in severe cases, severe depression cases, and if there is like suicide risk or suicide tendency, and if there is stupor. So these are the three indications for ECT. ECT is not given in any case. ECT is like the last option, or not the last option, but it's just given in severe cases, not in all cases. Then there is transcranial magnetic stimulation. Transcranial magnetic stimulation. Transcranial magnetic stimulation. Now, magnetic waves are used to stimulate the neurons. Here, magnetic waves are used to stimulate neurons. This is a very difficult therapy to do, and like there are special trainings for doing transcranial magnetic stimulation. But for now, just for us, we just need to know this, that is, what is it basically? Magnetic waves are used to stimulate the neurons. And special mention worthy point is that we don't need here no anesthetics. So no role of anesthesia. We don't need any anesthetics here in this procedure. And then side effects are very less. Very less. Not even worthy to mention. Then there is another modality is vagal nerve stimulation. So CN10, the cranial nerve 10 or vagal nerve, is stimulated using electrodes. Then there can be deep brain stimulation. That is, their leads are implanted in specific brain areas in this procedure. Lead implantation in specific areas of brain. Sleep deprivation. Now, lots of studies have in psychiatry have shown that depriving the patient of chronic depression from sleep in many cases have improved the symptoms like hell. They have improved the symptoms. But this is a subject of research. As I said, this is a lot of studies have shown it. This is subject of research yet. So this is not a confirmed method of clinic in like used all the times in the clinics. And phototherapy. Last is phototherapy. This is mainly for this phototherapy is mainly used in seasonally affective disorder, in, like I said, in the types of depressive disorder, seasonal affective disorders. That is, a person feels depression only in some specific season, maybe in winter or autumn or summer, like that. seasonal, for seasonal affective depression or depressive disorder. And this seasonal affective depressive disorder mostly is found in, let's write it in blue, mostly in winter. So thus we come to end of a big topic in psychiatry, that is, and mood disorders, big topic in mood disorders of psychiatry, that is the depressive disorders. I hope you have enjoyed and liked the video. Please do share the video with your friends, colleagues. Do subscribe to my channel because that helps me a lot, encourages me a lot to make more videos like this, and don't forget to like the video. Thank you.